Good afternoon, everyone, and welcome to the UEG Guideline Webinar number 3. The topic of this day is microscopic colitis from guideline to clinical practice. I am proud to introduce you the two excellent speakers that we have now. The first is Andreas Münch, Associate Professor at the University Hospital in Linköping, Sweden, and also the President of European Microscopic Colitis Group. He initiated this group in 2010 in Stockholm, and now is very big of 35 members from 14 different European countries. And the other speakers is Stefan Milke. He's a private gastroenterologist in Hamburg, Germany, associated with the Epidemiology University, and he is a vice president of the European Microscopic Colitis Study Group and also the coordinator of that guideline. I remember also that after that guideline, we have also a mistakes in on that topic. But first of all, I ask the audience if every one of you is hearing us well, and we would like to know something on your background and your expertise. Which is your expertise? Please just contribute to the poll. Okay, well, the majority of the audience is gastroenterologists, but I am happy to see also some internal medicine specialists, some pathologists, and also some surgeons. And this is interesting because usually microscopic colitis is not a surgical disease, and we have also a 9% of other specialties. So I believe that this will bring surely to a great debate. But now let's go directly to the point, and I'm very happy to introduce Professor Stefan Miehlke. And Stefan, it's up to you.
Thank you, Gianluca, for the kind introduction, and hello, everyone. My name is Stefan Miehlke, and it's a real pleasure for me to join this webinar with you and together with Andreas to talk with you about microscopic colitis from guideline to clinical practice. So I will touch the first base with this and tell you a little bit about the guideline, and Andreas will draw your attention on clinical practice issues and common mistakes in microscopic colitis. This is my disclosure. And I have to say, it's really great to see this large audience. We have more than 200 participants in this webinar and from all over the world. So that's really great to see. So this is a European guideline which was published in August last year, and I would really acknowledge all the co-workers who have really contributed a lot to this guideline. We were overall 32 physicians and researchers from 14 European countries, and we reviewed the literature until July 2019. The guideline was made based on current methodology with grade and agree. And overall, we came up with 39 statements and recommendations in this guideline. It's open access, so you can read the paper in more detail if you're interested in the very details. We can here touch only a few aspects. Now, at the beginning, I would like to catch your attention a little bit more with two questions. And I asked for your vote. And the first question would be, how do you estimate the frequency of microscopic colitis in comparison to traditional IBD, ulcerative colitis and Crohn's disease? Less common, similar, more common, or it may depend on the geographic region. It's not about right or wrong. We just want to have your opinions, and let's see how the vote will look like. Okay, there seems to be a majority of about 60% who say it's less common. About 50% say it's similar, 12% more common, and 18%, 17% say it depends on the geographic region. Of course, there are different possibilities to answer this question, and more or less you are all right. So, now then we keep this in mind, these numbers, and then we can discuss it later on when we see some more data. So the second question would be, how do you estimate the proportion of MC patients with chronic relapsing course of disease? Less than 20%, 20 to 40%, 40 to 60, 60 to 80, or more than 80%. So based on your knowledge of the literature or of your own personal experience, clinical experience. And this is something Andreas will also address in his presentation. Well, that's so about 1/3 estimate the relapse rate between 20 and 40%, and 40 to 60% is judged by 22%. So the majority, if we take these two together, it's probably very close to the reality. So that's a very interesting vote. Again, we keep these numbers in mind and then look at some data and then discuss it later on after our two presentations. So this is the current epidemiology, which was also addressed in the European guidelines. So we made a meta-analysis of the literature to analyze the incidence and prevalence of microscopic colitis and also the frequency in chronic watery diarrhea. So what you can see on first sight that it's quite a large heterogeneity about the reported incidence rates in various countries. So there's quite a range. So it may depend on geographic regions, on multiple things like diagnostic criteria, awareness, and whatever. Other factors may play a role, but it's quite a range of reported incidence rates. On prevalence, there are only very few studies which have been identified and analyzed here. And with the frequency in chronic diarrhea, so patients with normal or almost normal endoscopic appearance and chronic watery diarrhea, again, you can see a wide range of rates of frequencies. And overall, we calculated a pooled incidence rate of 11.4 per 100,000 person years based on this meta-analysis. The pooled overall prevalence was roughly 120 per 100 persons. So it's actually quite similar to a traditional IBD. And the pooled frequency of microscopic colitis in patients with chronic watery diarrhea and normal endoscopic appearance was about 13%. So at least 1 out of 10 of those patients will have microscopic colitis. So we also looked at risk factors for microscopic colitis, and obviously the two most important risk factors are smoking and drugs. This is well established and well known, and this is one of the latest studies looking at smoking in microscopic colitis. This was an analysis of 2 large prospective cohort studies from US Women, the National Health Study in the US. And this study has clearly shown and confirmed that smoking, especially active smoking, current smoking, but also past smoking, is a significant risk factor for microscopic colitis. There also seems to be a dose-dependent effect. The longer the smoking in pack years, the higher the risk for microscopic colitis, but also the other way around. And this was shown for the first time in this study, that the years since smoking discontinuation was also associated with a decreasing risk of microscopic colitis. So, and based on this study and other studies, we concluded that former, but especially current smoking is associated with an increased risk of both collagenous and lymphocytic colitis. However, there's insufficient evidence to evaluate really the influence of smoking cessation on disease course. There are no prospective studies on this, but again, we recommend to do so in patients who are active smokers and have microscopic colitis. Now, the second important group of risk factors are clearly drugs, and there are multiple studies published in the literature. This is one of the more recent studies from Denmark, which is very well done. It's a nationwide registry-based study with more than 10,000 cases of microscopic colitis. And on the left is collagenous colitis, on the right is lymphocytic colitis. And as you can see, PPIs were clearly associated with an increased risk for microscopic colitis. NSAID alone were also associated with a slightly increased risk. But if these two drugs come together, then the risk is even higher with 7.45 in the odds ratio. And the same was true for lymphocytic colitis. PPI was associated with a higher risk, NSAID as well, and the combination seems to be also increasing the risk for lymphocytic colitis as well. And this is a second interesting study published a couple of years ago based on UK data. And here it was shown, and this is why I want to show it to you, that there's an increased risk from the beginning when patients taking these drugs. And then it seemed to be increasing during the first 1 to 2 years if they have continuous drug use, and then the risk seems to drop off again with more continuous use over more months and years. So this seems to be the phase where the risk is the highest to develop microscopic colitis. And this should be kept in mind when we look at patients with a new diagnosis and the history of drugs. We should keep these data in mind. And this was shown also for PPI and for SSRIs in this study. So based on this and other studies, we concluded in the guideline that chronic or frequent use of PPI, NSAID, or SSRI is associated with an increased risk of microscopic colitis. However, this does not imply a causal relationship. We don't know the mechanisms, how these drugs really contribute to the development of microscopic colitis. This is largely unknown. And we consider withdrawal, we suggest withdrawal of any drug with a suspected chronological relationship between drug introduction and onset of diarrhea. Now, moving on to clinical manifestation of microscopic colitis, as you all know, and it's well established that watery diarrhea is the prominent symptom of microscopic colitis, and this is a collection of 3 large cohort studies from Sweden, Denmark, and Germany with a total of 1,800 patients. And as you can see, watery diarrhea is really the dominant symptom, but it's not the only symptom. As you can see down here, other symptoms are quite frequent in microscopic colitis, especially nocturnal diarrhea. And this is also important to discriminate these patients from irritable bowel disease because they usually don't have that. Fecal urgency is quite common, and patients are quite suffering from this particular symptoms. And also abdominal pain and mild weight loss may occur in microscopic colitis. So it's quite a range of symptom burden associated with this disease. And of course, this has an impact on quality of life of these patients. And this is what just one study, a large study with more than 200 patients, where quality of life was assessed with short health scale. And as you can see, again, collagenous colitis on the left side, lymphocytic colitis on the right side. If the patients have active disease, these are the dark columns, quality of life is really deteriorated, significantly deteriorated. And if patients are in remission, either by treatment or spontaneously, quality of life is comparable to the normal controls. So there's a lot of evidence that this is true, and Andreas will touch upon this later on when he talks about the Holtzmann criteria. So we concluded that the most common symptoms of microscopic colitis is chronic watery non-bloody diarrhea, which is frequently associated with concomitant symptoms, including fecal urgency, nocturnal stools, and fecal incontinence. Health-related quality of life is impaired, significantly impaired, in patients with active microscopic colitis, again, depending on the activity and severity of the disease and also on concomitant comorbidities. And disease activity and clinical remission should be assessed by the Holtzmann criteria. I will skip this here. Andreas will touch this issue more in detail because this is right now the only criteria we can really use to discriminate between active and non-active patients. And Andreas will address this later on. Now, the diagnosis, this is nothing new, is based on histology. This is why it's called microscopic colitis, and you are well aware with the histological features. I will touch later on. Endoscopy is usually normal or subnormal. If you look at the literature, and this was a recent review article with more than 1,500 patients, there are a lot of endoscopic findings actually described, like erythema, friability, scarring, etc. But again, all these findings are unspecific and they are not predictive for microscopic colitis. So it's always easy later on to say, okay, it looked abnormal when you have the histology, but it's not predictive. But it's reported quite common in up to 38% of cases in this large collection of patients in this review. So we have to keep this in mind and to be well aware about this, and maybe this helps also to target biopsies. Now, this is a diagnostic algorithm which we developed a few years ago with the European Society of Pathology and the EMCG together. And this recommends how pathologists should look at this. If they see increased mononuclear inflammation in the lamina propria and they observe normal architecture, then they should count the intraepithelial lymphocytes, and they should assess the thickness of the subepithelial collagenous band. If this is more than 10 micrometers on H&E staining or maybe on special stains, then the diagnosis of collagenous colitis is confirmed. If it's somewhere in between 5 and 10 micrometer, we like to call this incomplete collagenous colitis. And if the collagenous band is normal and they have increased intraepithelial lymphocytes, if it's more than 20 IELs, then and the collagenous band is normal, then lymphocytic colitis is confirmed. If it's less than 20 but more than 10, it should be diagnosed as incomplete lymphocytic colitis. And this has also been summarized and concluded in the guideline. Nothing has changed since then. 10 micrometers or more is the threshold, the diagnostic threshold for collagenous colitis, lymphocytic colitis, more than 20 per intraepithelial lymphocytes, and a normal collagenous band. And here in this guideline, we also define the criteria for incomplete collagenous colitis, as just mentioned, and incomplete lymphocytic colitis you can find here as well. What about fecal biomarkers? There are plenty of studies out there. And again, this is a review article summarizing all these studies. As you can see, there are several biomarkers, fecal biomarkers, that has been assessed, derived from different inflammatory cells in the colonic mucosa. And as you can, maybe if you can see this, there has been significant differences between MC patients and control groups. However, the number of patients in these studies were rather small, and there was quite a huge overlap between the measurements of these biomarkers. So the conclusion of this article at that time was, so far none of these tested molecules present sufficient accuracy for use in clinic practice. And basically nothing has changed since then, unfortunately. So we had to conclude that fecal calprotectin is not useful to exclude or monitor microscopic colitis, and this is also true for other fecal biomarkers. Some other recommendations for diagnosis of microscopic colitis: of course, ileocolonoscopy is recommended to assess patients with chronic diarrhea. And based on recent data that we have now from several investigations, suggest that it's enough to take biopsies from the right and the left colon. So we don't have to biopsy the entire colon, all segments. It's enough to biopsy the right and the left colon. Left colon meaning descending colon, not sigmoid colon and not rectum, because histology is not that prominent in these areas. So by this recommendation, you can actually decrease the number of biopsies in your clinical practice and make it and still be sure to make the diagnosis safely. We recommend screening for celiac disease in patients with microscopic colitis, because the prevalence of celiac disease is about 10-fold higher compared to the normal population. And testing for bile acid diarrhea can be considered in patients with refractory disease, because it's maybe associated with microscopic colitis, but we don't recommend this as in routine practice, and it's not available, or it's not easily available in many countries. So this can be something to be considered in a subgroup of patients to see if this contributes to the diarrhea. Moving on to treatment, of course, as you all know, budesonide is the mainstay of treatment of microscopic colitis. Today, we have 7 randomized placebo-controlled trials, 4 in collagenous colitis, 3 in lymphocytic colitis. And as you can see, we have a high rate of clinical remission after 6 to 8 weeks, and highly significant compared to placebo. This has also been analyzed in the European guideline by meta-analysis. And here on the left side, the studies on collagenous colitis, and the pooled clinical remission rate was 81% compared to 26% with placebo. And for lymphocytic colitis, it was very similar, 84%, with a little bit higher rate, placebo response rate of 43%, but again was highly significant. So confirming that budesonide is highly effective for induction of remission in microscopic colitis. On maintenance therapy, we have 3 studies until today. So these were patients who were brought into remission with budesonide 9 milligram and then randomized to 6 milligram for 6 months. We have 2 studies on this, and 1 study investigated 4.5 milligram per day for 12 months. And as you can see, budesonide is highly effective to maintain remission, about 75% of patients after 6 months. And this is the German study. This was a study from Denmark, and this was a European multi-center trial with about a little bit more than 60% clinical remission after 1 year with a low dose of 4.5 milligram per day. And if you look at the placebo groups, this is a drug withdrawal experience. So here you can see that actually 60% of patients relapsed in the placebo group, even higher after 6 months without treatment. So this is one of the answer to the multiple choice question we had at the beginning. And this was also be shown in the Danish trial with the placebo curve, about 60 to 80% relapse rate in the placebo group. And it was also shown in this study and also in the other study that if you stop maintenance treatment, the patients will also relapse in the same fashion as they relapse after induction therapy, indicating that these groups of patients may need long-term low-dose maintenance treatment with budesonide. Now, what about mesalazine? Mesalazine has been recommended, or if you look at previous articles, previous guidelines or review articles, there was also mesalazine recommended. However, today we have 2 randomized controlled trials showing that mesalazine is probably not effective at all in microscopic colitis. This was on collagenous colitis and on the right lymphocytic colitis, small number of patients, and this was not the primary endpoint here in this study. But as you can see, the clinical remission rate with mesalazine was rather low and not higher than placebo. So based on these studies, we don't recommend the use of mesalazine to treat microscopic colitis. What else do we have? Immunomodulators and biologicals. Andreas will address this in more detail. This is just one recent study, so far one of the largest study from the Mayo Clinic, looking at more than 70 patients, mostly patients who were either budesonide dependent or had refractory disease. And these patients, as you can see, were treated with thiopurines, 49 patients, methotrexate, anti-TNF therapy in 10 patients. And here you can see the response rates. There was quite a response in clinical remission, partial remission with these interventions. So these are options. However, the numbers that we have today are quite small. And Andreas will touch this later on and also report from some more experience from Sweden, from his center. So finally, this is the treatment algorithm we propose in the European guideline. Most of it is very familiar with you. If you have patients with active disease, then you start with induction therapy with budesonide 9 milligram for 6 to 8 weeks. So this should be really the standard of care today. And then you should stop treatment and see what happens when you have clinical remission, because a subgroup of patients will have quiescent disease. They don't have relapse and they don't need any further treatment. If the patients will have a clinical relapse, then you can start again with reinduction with 9 milligram. And then if the patients turned out to be chronic active, you should continue with low dose maintenance therapy, meaning 3 to 6 milligram per day. And of course, you can add also loperamide on demand if it's necessary. This is, of course, possible. If the patients have chronic active disease despite 6 milligram or more, then you should rethink, and then you have to do something else. And this is the red box here. This is something which is very individual, depending on the condition of the patient, etc., if it's a young patient or a very old patient. But these are the drugs you can consider in these situations, either the milder drugs, loperamide, cholestyramine, or in combination, or even biologicals like adalimumab or infliximab or vedolizumab. So this is a very individual decision how to treat this patient in this case. If you have primary clinical non-response, this is rare, but this can occur, and this is difficult to handle. Of course, you have to check that everything else has been ruled out. So you may need a clinical workup to identify other possible differential diagnoses, and if you find something, then treat accordingly. If this is not the case, you can of course consider also some more intense treatment with biologicals, for example, if it's a patient with very high clinical activity. So this is the current algorithm we propose, and we can discuss this later on. And with that, I would like to hand over to Andreas, and thank you for your attention so far.
So thank you very much, Stefan. And yes, good evening, everybody. I'm very happy to be here. And I want to start off by thanking the UEG that we have the opportunity to talk about microscopic colitis. Now, following Stefan's excellent talk, my task is to see how we can implement this guidelines into clinical practice. And I will show you some more recent studies, and I will talk about my personal experience in treating, for instance, budesonide refractory patients. I want to start off with epidemiology. And we have learned from Stefan that the annual incidence rate is about 11 per 100,000 inhabitants, which is quite common. But I think we have to put this into perspective and compare it, for instance, with ulcerative colitis and even Crohn's disease, because we hear so much about these other inflammatory bowel diseases. And here is a very recent study from Denmark. And Denmark is the country where you can do the best epidemiological studies because they take the whole population and they have these great registries. And here we see that microscopic colitis more or less exceeds incidences of ulcerative colitis and Crohn's. And this might come to a surprise. We have had the first question, but this is, for instance, in Denmark, but we have the same situation in France. And I think this has implications as you as a clinician, that you know that if you seek for this in chronic diarrhea patients, I think you will find microscopic colitis. It is a common disease. And now I'm very proud that I can show data from our prospective European Microscopes Register. This is, as you know, when we look at cohort studies and they were retrospective, having kind of limitations, we would say that microscopic colitis patients have a flare on average about 30%. But now, for the first time, we really have prospective data that shows that relapsing disease is about 34%, and chronic active disease is 50%, putting all together more than 50% of these patients have some kind of relapsing or chronic disease. So this is also the second question from Stefan. Now you have the answer. I think this is the best data we have out here. And this also has implications for us as clinicians, because this guides us how we should follow up these patients. I think it happens that we make the diagnosis, we treat the patients, and then we say goodbye. I think it's very important to educate our patients what are the clinical activity criteria, which I will talk about, and they should have a number they could call. In Linköping, I even asked our nurse to call these patients, every year, once a year, just to look that everything is fine. Because something happens that you find elderly women that find it totally normal to have 5 watery diarrhea. So we hear a lot of stories. So I think it is important that these patients have regular follow-ups. And here from the same study, we now have the treatment strategy within 1 year. So these are patients that have incidents, they had microscopic colitis for the first time, and how they are treated. We follow them every 3 months. And of course, at the beginning, induction therapy is that what is given, and this is mainly budesonide, and not that often within the year. But here it's the first time we can see that 25% of these patients, due to this relapsing and chronic course, have budesonide as maintenance. And this could be the lowest dose that keeps them into clinical remission. And even here, that's something new that comes up and pops up, that we see that we give a lot of on-demand treatment. And this is not just loperamide, this is also budesonide. So this is a new concept we will try to study even within the European Microscopic Colitis group. And even we should ask patients what they really want. How can we empower these patients to take control? Because we know that more than 55% of these patients have sudden onset of disease. So they always worry when it's going to strike again. So I think a lot of patients want to have budesonide at home, and maybe they want to take it as prophylaxis. Maybe they want to treat it as soon as they see that have watery diarrhea. I think we know this drug is safe, and we have to study this if this is a good way to go. Now I come with a question, and this is not right or wrong. This is just, I want to see your impression. In patients that have chronic diarrhea, what do you believe influences patients' quality of life more? Is it bowel frequency or is it bowel consistency? Okay, I believe we are getting a clear picture. It's 74% that say it's frequency. And I understand that, because that's the way the World Health Organization defines diarrhea. You have to have more than 3 bowel movements per day. And if you have a chronic, that's more than 4 weeks. But I might show you another picture. And I think microscopic colitis is a good model disease to study diarrhea. And when we go on, we have done a cross-sectional study in Sweden where we gave a lot of patients diaries and even questionnaires of quality of life. And this enabled us to calculate a cutoff when patients subjectively feel that they have active disease. And here you see that when we take a pointer here, that yes, when we take frequency, it should be more than 3 bowel movements per day. This is the mean of 7 days. But what is new, if we look at consistency, looking at watery and loose stools, which is Bristol School 6 and 7, you just need 1 watery diarrhea, and the patients feel subjectively, I have active disease, and also they demand treatment. And you can see this is the short health scale where we have different dimensions of quality of life. If they don't have any watery stool, then they feel fine. But as soon as 1 watery stool, the quality of life deteriorates to the same level as when we have 3, 4, 5, or 6 watery bowel movements. So this implies, in some sense, you could say that the quality of life is more negatively influenced by the consistency as the frequency. And this is maybe a new thinking for you. It's a question to you, do you treat a patient that just has 1 watery diarrhea? So please think about this. Yes, we have now pooled data from 3 randomized controlled trials, more than 200 patients, where we looked at each segment of the bowel. And what is new is that we really can now say that microscopic colitis is a pan-colitis. So you have an inflammation throughout the whole colon. And even the thick and collagenous layer is throughout the whole colon, not that much in the rectum, but the rest is. So this is important, of course, when you look at how you should take biopsies. It does enable us to say that it's sufficient to take 2 biopsies from the right-hand side and from the left-hand side. And that's enough to make a diagnosis. It's not patchy, it is a pan-colitis. Now coming to histology, this new concept of incomplete microscopic colitis. What is this all about? These are patients that have chronic watery diarrhea, yes. And then when you read the report of the pathologist, you really have to read between the lines. And pathologists might not like to count or even measure the collagenous band, but they might say it's falling short of the classical criteria of microscopic colitis. So this could be a borderline mucosa. We call it incomplete microscopic colitis. And why is this important? This is important because otherwise these patients would not get a diagnosis. And most certainly they would have the diagnosis IBS-D. But then they don't get the right treatment, because we know from cohort studies that budesonide works in the same way as for the classical other subgroups like collagenous colitis, lymphocytic colitis. Even in incomplete microscopic colitis, you could see a clear benefit. It's more than 80%. So I think this is worthwhile to try even in these patients, even if it's anti-inflammatory, but it seems also to have an anti-diarrheal effect, budesonide. So this is worthwhile to test these patients. And from our cohort studies, we know they're about 50% of the population. So I think you should even look at these cases more thoroughly. Now I come to another question. So please, the question is, how many MC patients fulfill the Rome-3 criteria for IBS? We have a meta-analysis. So could we have a vote on this? Okay, it seems to be divided between 33% and 44%. Good. Thank you very much. We'll go on. And we have now, a meta-analysis on this topic when we have microscopes versus IBS-D. This is something very important for the general practitioner. It's 44% of the MC patients fulfill the IBS criteria. And if you turn it around and say the very prevalent IBS-D group, how many of these patients would in the end have microscopic colitis? And this is 9%. So even here, quite a lot. So what can we do to distinguish between these two entities? I think it's very useful to use diaries. So ask the patients to fill a diary for at least 1 month. And what is the most distinct for your microscopic colitis patients is that they have water diarrhea. In 80% of the case, this is the case. And we see that the consistency and frequency is quite consistent with microscopic colitis, but this varies between IBS patients between day to day. And I think there are also other criteria we can use, just taking a thorough history. Yes, age could be important. And of course, IBS patients are younger. But please, you should know that even 25% of the patients who have microscopic colitis are beyond the age of 45. So you should not just think about elderly women. You should also see that these patients could be younger and even males. Yes, the distinction between nocturnal diarrhea, this is more common in microscopic colitis. This is clearly so. Whereas we have this feeling of incomplete bowel evacuation or bloating or fullness, this is classical IBS. Whereas what is common for microscopic colitis is weight loss. I think this is due to the fact that the patients do not eat because that's the way they can control their diarrhea. And fecal incontinence, yes, it's very common in microscopic colitis and maybe not that common in IBS, but it still exists. And then we know for microscopic colitis, there is this link and association to other autoimmune diseases like celiac disease, rheumatic disorders, and even thyroid disorders. I wrote down response to loperamide. What do I mean with this? In the clinical practice, I can see that when you ask, all patients have tested loperamide because you can get it over the counter. And in IBS, these patients can get constipation, a very strong reaction to this drug. Whereas in microscopic colitis, I think you can ameliorate the diarrhea, but it will never be constipation. So in this sense, you can hint to the one or the other, but this is not in any way evidence-based. This is just my clinical experience. Yes, once more to this calprotectin. Unfortunately, we don't have a biomarker, and we cannot use it to exclude or monitor the disease. As you can see here from the diagram from Signeville from Denmark. And this was, for instance, I learned from the UK, they use a cutoff of 100 at the general practitioner level to just to distinguish between who should get colonoscopy or not. And if you look at the results here, half of the patients had a value below 100. And then even if you treat them, you can see they rise in calprotectin. So how can you explain this? There's an explanation. I mean, microscopic colitis is not a neutrophil-derived inflammation where calprotectin comes from. It's more T lymphocytes. So there's an explanation to this, and we hopefully one time we will find a biomarker for this. But the only way to make the diagnosis is through colonoscopy and taking biopsies. Now coming to this topic, I mean, Stefan gave a very excellent overview of all the randomized controlled trial, and it is budesonide that is evidence-based. That's true. But in 5% of the patients, there are very few, but we all have these patients that do not respond to budesonide anymore. So how do you define budesonide refractoriness? So these are patients that still have active disease, despite the fact that they have 9 milligrams of budesonide as induction after 1 month. So if they're not better after 1 month, something is going wrong. And those that have 6 milligrams on maintenance treatment and more than 3 months and still have active disease, I think you have to think about switching the treatment. And then, of course, the few cases that we see that are intolerant against budesonide. And we have learned that the EMCG recommends thiopurines, anti-TNF, and even vedolizumab. But to be honest, we don't have any randomized controlled trials. These are just case series. You have to explain to your patient, this is experimental treatment, but I think you should give the hope and don't give up. And I just want to show you my experience from my hospital in Linköping, focusing on anti-TNF. This has been published. These were 18 patients, now have treated more than 30 patients. And what I want to point out is that these patients seem to be younger. In the average, they are 47 years of age. Of course, this is important for comorbidity and other things that you can give biological treatments. I think we have quite a long follow-up period here. It's 69 or even up to 95 months for the different anti-TNFs. And even here, I want to point out that a high degree of these patients are current smokers. So this corroborates the fact that we believe that we know that smoking is a risk factor. But unfortunately, we don't have any cessation studies where we can see when you stop smoking, does that really affect the treatment and even the watery diarrhea. So our experience in these 18 patients, if you look at the gray boxes, we have just the induction treatment. And here we see, and we used adalimumab and infliximab. So this is a mix of both. And 9% went into remission. So this is 50%. This looks really good. And six patients, 33%, had a response. And here we meant that they had improvement of clinical symptoms. And from those that went into remission, there was one that had a long-lasting remission on maintenance. And then we had even 3 patients that just got induction, and they had a long-lasting remission after that without maintenance. So something changed in their immune system, whereas the other 5, they had side effects or loss of response. And this was also for those that have response from the beginning. And what do you do if they fail on one treatment? I mean, you try a second line, or you just switch from adalimumab to infliximab, or vice versa. And here we can see in 7 patients that you give a second line treatment, then 3 of them went well, and they all are on maintenance treatment. 2 had even response. And here we have even those are either in remission or in response. So this is quite good data. I think we can say on average is more than 50% of these patients will respond to anti-TNF. And that's maybe a big step, but I think you should treat these patients as you do for your regular IBD patients. Apply the same rules, apply the same caution. So don't give up on patients that are budesonide refractory. And with this said, I would like to give my take-home messages. Yes, once more, MC is a common inflammatory bowel disease. If you seek for it, you will find it. And all patients, to my belief, even for those that are younger, if they have watery chronic diarrhea, I think they should be referred to colonoscopy. We know that abdominal pain is very common in microscopic colitis, so please don't misdiagnose as IBS. Calprotectin will not help us in this disorder. And we see that these patients have severely deteriorated quality of life if you have active disease. If you listen to your patients, you will hear incredible stories how they try to cope and manage this disease. And once more, coming back to this consistency and frequency issue, it is justified to treat patients that have less than 3 bowel movements. Even 1 watery bowel movement can make a difference. The patients worry and they feel that they are not able to do the things they want to do. And think about incomplete microscopic colitis. Please read between the lines when you get the pathology report, and even maybe try budesonide in those that already have tried loperamide or other treatments. And don't give budesonide refractory patients. Treat them and give them the same attention as your usual IBD patients. So thank you very much.
Thank you so much, Stefan and Andreas. I'm very happy of these amazing presentations, and thank you for your time and your expertise. They were really, really brilliant. There are some questions from the audience. Thank you for the participation. We have received a lot of questions, but so I will try to group them a little bit as we have no time for every question. First of all, the diet, the role of diet in microscopic colitis. Can you tell us more?
Well, there's one study looking at gluten-free diet or the impact of gluten on microscopic colitis, and there were 2 studies on this, and both were negative. So gluten seems not to be associated with the diarrhea and microscopic colitis, and on the other way around, gluten-free diet was not effective.
And are there any data on low Fodmap diet or maybe some exclusion diet, for example?
No formal studies on low Fodmap or anything, Andreas?
There's a small case series on patients that got elementary diet, which was quite positive, but this has never been studied in a larger series of patients. So no other diets as we know of Fodmap or anything else.
Okay, thank you. And we have received a lot of questions about the right way to do biopsies. So how many biopsies we should do and why we cannot do only in the left or only the right colon. And if we need also to check the mucosal healing and the histological healing instead of just clinical remission.
Well, we have studied this very systematically, and as Andreas said, yes, it's histologically it's pancolitis, but the inflammatory markers of the disease are more pronounced in the right colon, and this is the reason why we are not so happy with recommending only biopsies on the left colon, because in the right colon it's higher, and the second problem is with the left colon. If you biopsy the left colon, make sure that you biopsy the descending colon and not the sigmoid colon, because based on our studies and others, you can have a miss rate of up to 20% if you biopsy only the sigmoid, and this would be not sufficient for me. So this is why we recommended to biopsy at least the right and the left side. 2 biopsies from ascending and 2 biopsy from descending colon. This is the way I do it.
And I would like to add, when you send your biopsies, put them in different tubes,
yes,
and especially mention to the pathologist that you have the suspicion of microscopic colitis, because this will change the mindset of the pathologist to look more thoroughly.
And regarding the question of the histological follow-up, there's no need to do so, because the histological remission and clinical remission goes hand in hand. So if your patient is in clinical remission, there's no need to make a follow-up. A different story with a refractory patient, but we have no data that if at this point a follow-up endoscopy in a patient with if the diagnosis of MC is confirmed in the first place, there's no benefit from a follow-up histology at this point in time. Only if you are unsure about the diagnosis, but not a regular histological follow-up.
Okay, that's great. There are 2 important points in clinical practice for our audience. Other question, what about the maintenance therapy? So for how long do you continue maintenance therapy, and how do you do it? So for cycles through the years, or how?
That's an excellent question, because this is one of the most important questions. We only have these 3 trials, and Andreas has shown in the 1-year trial that if you stop treatment after 1 year, then the patients will relapse again. Of course, these are selected patients because they had to qualify for the trial and they had active disease in the very beginning. So this may not completely be representative for all MC patients. But in general, we recommend long-term or budesonide for maintenance therapy without a stopping date. So basically, the recommendation is indefinite. Of course, you have to treat, or you should treat as low as possible. And you can also think about, this is what Andreas addressed briefly, and what we want to study in the future about on-demand concepts. So not every patient may need 6 milligram every day, and not always. So it's not constant. So, and this is the way we treat these patients, and even in the long term, even for years. It's a fairly safe drug. There's not a lot to be concerned. And in my experience, and also experience from Denmark and Sweden, so this is the way we do it.
And I would ask, the question is always, how low can you go? And I have patients that have 3 milligrams every second day. But as soon as they stop that, it doesn't happen. So you can tell the patients that they can, below 6 milligrams, they can try as soon as much. But then on the other hand, you have to be rational. If you have a 90-year-old lady that's lying in bed, I mean, and she responds just to 9 milligrams, give it, okay? At least she doesn't have any problem. You have to have a rational approach to this. I mean, budesonide is not the systemic prednisolone, okay? It's a different drug. And so this has to be kept in mind, and you have to discuss this with your patients. Everybody's afraid of steroid side effects, but there's a difference between budesonide and prednisolone.
Okay, and in that context, what about the enteric-coated budesonide? Do you have experience in that setting of patients?
Well, we have different formulations. We have the budenophilic formulation, we have Entocort, and we have MMX budesonide. All the randomized control trials have been done with budenophilic or Entocort, and there don't seem to be a difference in efficacy. So I think they are the same. With MMX budesonide, there are only very few data available. No randomized control trial, but it has been approved recently for short-term treatment. So, but in the end, I don't think it makes any difference.
Okay, thank you. We have some more minutes. So, what is the role of calprotectin in microscopic colitis?
I think we can make it short. We both have mentioned this. Yeah. It has no place to exclude or monitor the disease. So please don't use it as a marker to distinguish if you can give if patients should go to colonoscopy or not, and don't use it as a follow-up. We don't have a marker for microscopic colitis.
Yeah, even because it is expensive. So
there was also, Gianluca, I noticed also a question about bismuth. It's a very old drug.
Yes, bismuth.
It's always mentioned in older reviews and former guidelines. In the European guideline, we decided not to recommend bismuth because there are only very few and very small data. It's not enough for a firm recommendation, especially in long-term treatment. There are no robust data in long-term treatment, and there are concerns about neurotoxicity with bismuth in the long term. So I would not recommend this drug, and there are no data, and it's not available in many countries.
Well, the last two questions. First, several learners have asked about the pediatric microscopic colitis, so which is the epidemiology?
Well,
there's no data on that covers in some ways an catchment area. We know it can appear, but they're just case reports. This is very low figures in children.
Okay, well, and the final questions. If you find also some increase in eosinophiles and together some lymphocytes or some collagenous band, do you have an overlap between eosinophilic and microscopic colitis or whatever?
Well, eosinophilic colitis is very, very rare, at least in my experience, and there may be some histological follow-up, but in the end, you would treat them the same way because in eosinophilic colitis, there are no validated cutoffs. How many eosinophils has to be there? It's not validated, and in my experience, I have a few patients with eosinophilic inflammation or in combination, and they do respond the same way to budesonide like the other MC patients.
Okay, and the very last questions. Someone has asked about the immunotherapy dependent microscopic colitis, but more widely I ask, which are the new drugs that we should be aware of that of their risk of microscopic colitis?
Maybe I can answer. I mean, we have just case reports, and when we look at all the biological treatments, first place would be anti-TNF. We have quite some cases on that cases. Vedolizumab, we have published 11 cases where 5 have responded. I personally in Linköping have treated 12 patients. This is not published, but we have to get this data out there. We'll see what we have response on that. I have treated patients, selective patients with Stelara, ustekinumab, and even now with Celiac, and have single cases that might have responded. And I will always look what they also have for different other diseases. They have psoriasis or rheumatic diseases. It could be interesting to combine a treatment that covers 2 diseases at the same time. But you have to enlighten your patient that you're doing very experimental treatment, and I mean, but still you can maybe have some hope that it will work out. And so in single cases, I think you can test this, but we will have difficulties making good trials in these patients. There are so few.
Okay, well, thank you very much.
There was also, Andreas, one question about the dosing of anti-TNF in MC patients. Do you want to comment?
Yes, I should have mentioned that. That's very good, because I see my clinical experience that these patients, they need more than we used to. So I have a lot of patients with 80 milligrams every second week, or I just shorten the interval with 40 milligrams adalimumab every week. This is not uncommon. So there is some kind of a dose response. We see that, yes.
Okay, well, so we have to close, but thank you again to the both of you, and we'll conclude by inviting you to check the next mixtape in microscopic colitis and how to avoid them by Andreas, which is now online in the UEG website education section. And in May 2021, we will have also the guideline on microscopic colitis available in the GI guideline app developed by the Quality Task Force. And I thank also all the participants for their participation and their interaction. And we'll invite you to the next events of the UEG Quality of Care Task Force. Thank you and bye.
Bye-bye.
Thank you. Bye-bye.